One way in which the healthcare industry is unique is that it touches everyone. We all, at various points in our lives, interact with various providers of healthcare. But we're at a very interesting place in the evolution of that industry. On one hand, we have many amazing developments happening every day. But we also face many challenges. Forrest Faison is a retired vice admiral in the United States Navy, who served as an officer in the Medical Corps, culminating as the United States Navy's 38th Surgeon General. Since retiring from the Navy, he has served as the Senior Vice President for Research and Innovation and Chief Healthcare Strategy Officer at Cleveland State University. He truly has a unique set of top-level experiences as a healthcare and medical emergency response leader, and he joined us to talk about the future of healthcare and much more. We hope you enjoy this phenomenal conversation with Dr., Admiral, and my fellow Cleveland State University colleague, Forrest Faison. Welcome to the Indigo Podcast, an exploration of human flourishing at work and beyond. I'm Ben Barron of Indigo Anchor and Cleveland State University.
And I'm Chris Everett of Indigo Anchor. For more information, please visit us at www.indigopodcast.com.
Well, Forrest Faison, welcome to the Indigo Podcast.
Thank you, Ben. It's great to be here.
Yes, this is so awesome. I've been looking forward to this ever since we prepped. I mean, that Forrest has such good stuff to say, and he's one of the people, I've met some military leaders that are kind of lost in the sauce a little bit, and that is not this guy. He knows what he's talking about. He's a thought leader in this space, and on top of that, he has just mounds and mounds of practical experiences in the trenches on this stuff at the strategic level all the way to the tactical level. There couldn't be a better person. I mean, thanks for coming on.
Thanks, Chris. Thank you so much. It's a real privilege to be here, I'll tell you.
Yeah, well, we're so excited, and what we're going to talk about here today are a few things. We're going to talk about some major trends in the future of healthcare. We're going to talk a little bit perhaps about managing health emergencies at a large scale, and we'll talk maybe about some of those lessons learned from being the 38th Surgeon General of the U.S. Navy. So why don't we kind of start with this big topic, and just from your perspective, being a physician yourself and, working all the way through to the highest levels of, being a healthcare executive, so to speak, in the military, and now continuing that in your role at Cleveland State and so forth. Tell us a little bit about what you see about some of these major trends in the future of healthcare.
I'll tell you, healthcare, and American healthcare specifically, but really globally, is undergoing change on an unprecedented level that we really have not seen in generations. It's really what I call the tectonic plates of change. For really centuries, the model of healthcare has been pretty stable. You go to a facility, whether that's a hospital or a clinic, when you're sick. You go, when the doc says you can go, you get good care. It's a very stable model. That is really changing. These tectonic plates are shifting healthcare in ways that we have never seen before, and they're coming together all at once. So when you look at healthcare, for years and years, like I say, healthcare was very stable. Now it has ultimately become a commodity. People need it, but they don't need it from a particular entity. Healthcare is very heavily regulated in the United States, and that regulation has driven out the bad actors. So pretty much anywhere you go, you're going to get pretty decent care. So what drives healthcare choice today? Because it's not cost, because you're not paying for it, and it's convenience. You're going to go where it's convenient for you, where it can fit into your life. And this has given rise to retail health clinics. This has given rise to, virtual healthcare solutions. So we've moved healthcare into the community driven by convenience. And that's good. There's goodness that goes with this because it makes it easier to get healthcare. The challenge is, how do you do that when and not have your healthcare get fragmented? So you get your care from one retail clinic today, you go to your doc the next day, another retail clinic the day after that. None of those are connected by a common electronic health record. So what that means that you're at risk for your care to become fragmented. Tests have to be repeated, diagnoses have to be re-explored, ultimate costs of care go up. And our country can't afford that right now. $1 out of every $5 in the GDP is spent on healthcare. We need to be looking at how do we control the cost without sacrificing quality and access, not catering to convenience and allowing the costs go up in an uncontrolled manner. That's one area. The second area is what we just saw, the pandemics. Pandemics have been a part of human history since antiquity. But what has changed is the speed by which they progress. So as an example, in the Middle Ages, the Black Death entered Europe through Italy, ports in Italy. And they came from Middle Europe, from the eastern part of Europe and the steppes of Russia and trading posts there. It took 5 years for the Black Death to get from Italy to England. 5 years. Today, you could, thanks to the miracle of air travel, you can be anywhere in the world well within the incubation period of a lethal infectious disease. So our response time, our window of opportunity to prepare and respond to that is really very short and is getting shorter. So you've got that, and I'm sure we'll talk about pandemic lessons learned. You've got the volume of medical knowledge. The volume of medical knowledge today is doubling every 73 days. We are rapidly approaching a point where it will be impossible for the human brain of your doctor to know everything needed to care for you. So driving decision support and care algorithms and best practices to the point of care is going to be important. Institute of Medicine issued a report a few years ago that to err as human, there are 100,000 preventable deaths every year because of variability in healthcare. So what's our plan for that? We don't have one. And then finally, the health workforce. As the baby boomers start to retire, our nation is facing a shortage of anywhere from 110 to 130,000 physicians by the end of the decade. So what's our plan for that? How are we growing medical school admissions? How are we extending care extenders and growing those? And we're faced now with something that we really didn't see before, which is the rise of competing career paths. My son's a good example of this. My son is in college right now studying cybersecurity. And I said, hey, what about a career in medicine, the family business? And he goes, Dad, why would I go through all that training and incur all that debt when I can get right out of college doing cybersecurity and make more money than you? I can't really argue with that. So who's going to carry on the mantle of healthcare into the future as we look at that? And then the last tectonic plate for America is the cost of healthcare. We spend 1 out of every $5 of the GDP on healthcare, but we do not have the best outcomes for that. 80% of those dollars for you individually will be spent in the last 2 years of your life. And much of that will be for what I call diseases of choice. These are lifestyle diseases, obesity, diabetes from diet and lack of exercise, and things like that are very preventable. But how do we take things like virtual healthcare and lifestyle modifications and career opportunities and bring this into a coordinated plan for the health of our nation going forward? That's our challenges.
Yeah, I'm so glad you brought those up. And I think those are great. Those kind of tectonic plates is a great way to look at those. So let's unpack each one of those a little bit. So the first one is convenience and fragmented care. One of the things when I was a kid, people used to say, oh, go see Filson. He's a really good doctor. And it wasn't, hey, if you can pass your medical boards, you've met standard, all right? As long as your bedside manner is dialed, you should be all right from a quality of care. But the difference in that is that there was a relationship with a health. I saw my pediatrician until he told me I couldn't see him anymore.
Yeah, that's exactly right.
And we don't have that anymore, right?
Yeah. No, healthcare's changed today. It's driven by convenience because again, the underlying assumption, and it's largely true, is that quality is there. You're going to get good care because healthcare is so heavily regulated. The curriculums are standardized across the nation, a variety of other things. Sure, there are some centers of excellence for specific disease conditions, but for routine primary care, healthcare is pretty ubiquitously of high quality in the United States. So convenience is what drives this today. And again, you when you're going after healthcare because of convenience, you're not going to have that relationship. When you're seeing a different provider each time you go in, again, driven by convenience, that provider's not going to get to know you. And what does that mean? That provider is not going to have at their disposal what I consider to be very invaluable tools in the toolkit of a healthcare provider, which is knowing your patient and knowing when something's not right. As a pediatrician, most of my patients can't tell me what's wrong with them, but as I know them and as I observe them, then I can tell when something's not right. You lose that when care becomes fragmented like that. And then the cost of healthcare goes up as tests get repeated. When you start to, everybody prescribes medications and there's med interactions that impact health. All of these things are coming together where the drive is toward convenience, but there are costs in terms of quality, in terms of outcomes, and in terms of cost.
Yeah, I don't think a lot of people knew this. When I was listening to the pitch for the Affordable Care Act, colloquially known as Obamacare, electronic medical records, and my generation's like, why aren't they electronic? And the mental picture we got, right? I think a lot of people in my generation did was, if I break my leg skiing in Colorado, they can get my medical records from Alabama. But they can't, because all these medical people are trying to find patients with money and make them sticky to their system no matter what they have to do. So that impacts it. And then on top of that, I got a sore throat, I'll just go to a doc in a box. We're missing out on this opportunity for kind of a longitudinal care with one person.
Yeah, there's a couple opportunities that I think we're missing out on that you allude to. One is we don't have a common electronic health record. Singapore is an example. Their health system operates off one health record. So that scenario you just suggested of you live in Ohio, but you go skiing in Colorado and you break your leg, the doc in Colorado is going to have access to your health record if you're in Singapore because it's one common health record. We don't have that in the United States. There's all different types of health records out there, many of which don't talk to each other. That's one issue. The second issue, which is probably a bigger issue, is we are awash in data. As we were talking yesterday, all of us are Amazon Prime members, as an example. Think about the data that generates. When you're buying things at 2:00 in the morning, you're probably not getting good sleep. When you are buying things that are high calorie, high fat snacks from Whole Foods, as an example, or something like that, then your diet's probably not that good. So, but all that data is out there. How do we bring that data in to use to improve our health? Because the amount of time that you actually spend in a doctor's office is well less than 1% of your total life. To sit there and think that is going to impact the other 99.999% of your life is really ludicrous. You really need to look at it holistically. What are your lifestyle things? What are the things that you are doing? And how can we bring that data to bear to improve the overall health of someone? It's what we call population health. And it's not just for the individual patient, but it's for the population. What are the factors that are impacting your health? We really missed that opportunity by having fragmented care and without having a common electronic health record to capture that data.
Well, and what's interesting too is that you mentioned Amazon. You're buying all of these things. Perhaps you're shopping at Whole Foods, which is also connected with Amazon, of course. And, those data are being collected. So it seems like, there is an opportunity for someone like Amazon to collect all these data and potentially, I don't know, there's probably some upsides and downsides to them having all of those data about you, but they probably going to be trying to sell you some healthcare. And I know they're starting to venture into that space.
Yeah, they are. I mean, you sit there and think about this. 70% of what goes into a primary care clinic doesn't need to see a physician. So like, as we were talking about yesterday, we're all Prime members. And this is not unique to Amazon. This could be any online service provider. And maybe as part of their Prime offering or one of the other online providers, part of their offering, you get, for being a member, you get, a tablet where you have on-demand access any time of day or night to a PA or nurse practitioner. So here's the scenario. You get up in the morning, you got a little scratchy throat, not feeling so great. You come downstairs in your fuzzy bedroom slippers, you make your coffee, you sit at the table, and you push the on button on your tablet. And up comes a PA or a nurse practitioner. Hey, how can I help you today, Mr. Faison? Well, I got a scratchy throat, I'm not feeling kind of achy, blah, blah, blah. It sounds like you got the flu. Well, you're in an urban market where we're testing drone delivery. I'm going to write you for some meds that the drone will deliver to your house within the hour. Please take that that piece of plastic with the QCR code on it and put it in your front yard so the drone knows where to drop the medicine. And while you're here, hey, thank you for using our free electronic health record that's part of our app. I noticed your cholesterol is a little high. Thank you for entering your labs in there. If you'll get your food through our online shopping service, then I'm prepared to offer you a deep discount on fat-free foods, and then make arrangements for you to get a repeat cholesterol test at the drugstore around the corner from where you live in 3 months. And I also notice you do a lot of shopping at 2 o'clock in the morning. You're probably not sleeping too well. So I'm prepared to offer you at a discount some sleep aids to help you with that, and some things that can help you get better sleep. And I also noticed that your weight's been trending up. And again, thank you for entering that into our electronic health record. We've entered into an agreement with Planet Fitness, let's use that as an example, where I will cover the first year of your gym membership for free, and you get 50% off future gym memberships. And then I'll give you a 20% discount on future purchases of gym gear and other things to help you lose weight and to stay in shape, all for being one of our select clientele members. So you sit there and think about this for a second. You went in there to get some Chloraseptic and some Theraflu, and you came out with a plan for your nutrition, a plan for your cholesterol, and a plan for your fitness and weight. Why would you ever go to see a doctor? Think about that for a second.
well, yeah, and Amazon just figures out how to giant vacuum all your cash out of your wallet.
Yeah.
You're like, wow, I'm so healthy, but I can't afford anything else.
I mean, think about that. Think about that. So that personal relationship that you build, that's so important for knowing when something's not right. What happens to that? And all that information that's in those servers for that online provider. What happens when you get your care the next day from another online provider, or from a retail store down the street that's got a walk-in clinic with it? How is that data shared? So again, care is at risk to become fragmented. And so what's our plan? And we don't have one.
Yeah. It's such an interesting set of uncharted waters for us with regard to how care is being delivered. And one other piece that you mentioned here, another force of change that I think is interesting and very important, is all about the healthcare workforce, right? And you mentioned how the numbers are low, right, in terms of the number of doctors that we need and those that are going into the profession. What do you see as some of the main drivers of fewer people going into medicine and that type of dilemma?
Yeah, I think there's several challenges that we've got for the healthcare workforce of the future. People are living longer than they did before. We are really looking at how do we take care of the population moving forward, and the people that will do that is the healthcare workforce. But again, what you're seeing is the rise of competing careers that don't require long training pipelines, that don't require you going into debt. The average medical student graduates with $250,000 in debt. When I was on active duty in the Navy, we did some studies to look at this because it helped inform our scholarship program. If you're a graduating college senior going to medical school, and let's just use a state school, not a high-end private, but a state school, and you take out just the average amount of student loans to go to medical school, and you go into orthopedics, which pays pretty well relative to other specialties, it's 17 years to pay those loans off. If you go into primary care, so that's pediatrics, internal medicine, and family practice or general practice, you never pay those loans off. You're in debt your entire professional career. So what are we seeing? We're seeing my son going into another career field that also provides him a good career opportunity, a good career trajectory, doesn't require a long training pipeline, doesn't require him going into debt. Of those that do go into medicine, we're seeing them go into specialties where they can pay their loans off. So it's not hard to get a residency in interventional radiology or things like that. It's harder for primary care because they got to pay their loans off. So what you're seeing is some of our graduate education programs are starting to close. So every year there are 1,000 more graduating medical students than there are residency slots for them to get their follow-on training in whatever specialty they go into. And again, so what's our plan for this? How do we build that primary care workforce? Because our entire health system is built on primary care. Right now, you go and see your family doc, to Chris's example earlier. You go and see your family doc with whom you've got a relationship, who knows you, who's going to take care of your primary care needs. And then when needed, that doc will refer you to a specialist. Our entire system is built on primary care. As we look to the future and drive healthcare into the community, we're not going to send surgeons and radiologists. We're going to send primary care people into the community. So what's our plan for that when people aren't going into primary care because it doesn't pay? And so that's the challenge that we've got. The other area that we've got a challenge is in mental health. Mental health is also right there with primary care. You never pay your loans off. So we are looking at a increasing demand for mental health services in our country because of COVID and things that are going on right now. The Health and Human Services did a study just a few years ago. There are thousands of counties without any flavor of mental health provider whatsoever in those counties. So there is a national shortage of mental health providers at a time when our need for mental health services is going up. So what's our plan for that? And there are mental health components to most of primary care conditions. What is our plan for that? We dealt with that when I was the Surgeon General, and we had folks coming back with post-traumatic stress and things like that. And they want to get on with their lives, but if they're going to a community where there's no mental health services, what's the plan for that? And so it steps back, and so we invest so much money as a country into plans for this, that, or the other thing, but actually taking care of ourselves as Americans. What's our plan?
I think that's so good. It's like shooting fish in a barrel. There's so many good ideas. Wow, most encounters don't require a primary care physician. Okay, well, maybe the PAs can start picking up some more like encounters and not having an encounter-driven model, but a outcome care-based model and those kinds of things. Yeah. To your point, we got to get with it. So go ahead.
Well, I was going to say, there's a couple interesting points with that. The first is we are very, very much a reactionary healthcare system. You get paid based on encounters. Meanwhile, the model, like in ancient China, so thousands of years ago, the physician was paid for every day the patient was well. But when the patient got sick, the physician didn't get paid. So you sit there and think about that. What can we do here? How can we shift to a healthcare system that focuses on wellness, and how can we incent and reimburse for wellness and keeping people healthy? Because again, most of the chronic diseases today are a result of lifestyle decisions that were made. And so how do we incent and influence those, especially in the late teens, early 20s, because that's when people are building up their habits for life. So how do we incent those things is something that we as a country have got to think about and move beyond reactionary healthcare. The other thing I would say is if you look at chronic disease as an example, and the fact that we don't have a plan, I was privileged when I was the Surgeon General to have the honor of caring for wounded warriors. And our country was so supportive, and is still so supportive of our wounded warriors. Because of advances in medical practice, and really the heroes on the battlefield, our corpsmen, combat medics, and folks like that, we had the highest combat survival in history in Iraq and Afghanistan. People who would have died in any previous conflict were going on with their entire lives ahead of them. But as we had visiting, elected officials and others come to visit us, I always ask them three questions. And although these apply to wounded warriors, think of these also for chronic illness, people with chronic conditions. What should the future look like for wounded warriors and their families? What should the future look like for people with diabetes and their families? What is our national strategy to achieve that future? And what's the role of the government? Because if we don't keep people healthy, we will lose the contributions of a generation. And so what's our plan for that? And that's why I say we really have got to come together as a nation and move beyond fragmented care that's reactionary, focused on when you get sick, into a holistic approach to the patient and keeping them well, and move beyond the current model.
Yeah, some strategy. Somebody needs to get rid of the stinking thinking and put on their strategy cap and start doing stuff. And some of this stuff has, I think, a real moral imperative. And it's about the kind of world we want to live in, not the world of like every corner's an Amazon store with a Starbucks attached. You know, if Amazon hadn't bought Starbucks by then, but to a place that is the kind of world we want to live in. Now, the final tectonic plate that you had mentioned here is about the explosion of medical knowledge. And I've been around several startups that are trying to do like physician decision support, because I don't think people know this, Forrest, that, patient 34 female presents with blah, blah, blah. I don't know. Let me see if I can catch Fred out in the hall. And I'll be right back. And they go out, right? And doctors try to catch other doctors in the hall. Or they looking it up in the physician PDR, the physician's desk reference, and try to make a diagnosis. But I can't find Sam in the hall. Oh, well, I guess we'll go with this when I get back, and best of luck. We're moving away from that now with technology. Riff on that a little bit, would you?
Yeah, I mean, if you sit there and think about it, you know, when you go to see the doctor, so let's use when you were a child and you went to see the pediatrician. You went to the Department of Pediatrics in some hospital to see your pediatrician. And you assume that regardless of what you had, that pediatrician was going to know how to take care of you. And that what that pediatrician did was going to be best medical practice. Well, both of those, let's think about this for a second. How you're trained depends on where you're trained and depends on who you trained you. You know, so for example, as a child, you have an ear infection, whether you get treated with Augmentin, erythromycin, or one of the other drugs, or you get treated with something totally different, it's going to depend on how that doctor was trained to treat ear infections, which is going to depend on who trained him, which creates variability in healthcare. And there's not enough time because you've got to see enough patients to pay your bills to go and look at best medical practice for every patient that comes to your door. So that's one issue that comes in. The second issue is when you see your doctor, they're going to develop what's called a differential diagnosis for your symptoms. So you come in with belly pain. Let's use that as an example. There's a whole bunch of different causes for belly pain. And your doctor is going to develop, here's a list of potential causes for belly pain. That list is going to be determined by what that doctor's seen. If that doctor has never been to Western Africa, as an example, and you have, but you forgot to tell him that, then he may not think about a parasitic disease that you might. So your differential diagnosis is confined to the experience of your doctor. Well, we're at a point right now where there's so much explosion in medical knowledge, and technology is so advanced and bandwidth is ubiquitously available that shame on us if we don't figure out how to take decision support that's timely and in real time and drive it to the point of care, to give that physician the tools and information he needs to give you a complete diagnosis and to ensure that his treatment not isn't necessarily represented on where he trained, but represented on best medical practice available at that point in time. That's where we really need to go if we really want to keep people healthy.
Yeah, so it sounds like, there's some great promise that potentially could come with our IT advancements and using that for more decision support to deal with and capitalize on and properly exploit this explosion of medical knowledge. And it seems like that's a positive thing. But some of these other big trends in healthcare, right, there are kind of positives. There's also negatives. And, if I'm a listener, I might be thinking, man, I'm a little bit scared about the future of healthcare. Are there things that you see as, positive ways forward, or, if you could wave a magic wand, things that you would do to our healthcare system that potentially could start moving us in the right direction?
Yeah, I think the future's bright if we're smart enough to pull these pieces together. I mean, if you sit there and think about it, when I was training, a few years ago, that's all I'll say about that. The diseases that were lethal are now curable. When I was an intern, HIV had not yet been described. Then it became a lethal disease. Now it's a chronic disease that's manageable. As one example, there were cancers. As a pediatrician, there were childhood cancers that were lethal that today are curable. We have unlocked the genetic code. As an example, think about like 23andMe or Ancestry.com, where you can get your genetic test, and the hundreds and hundreds of thousands of people that have done that. You have an unparalleled genetic repository to start looking at genetic basis of disease, and then to start to build treatments to be able to do this. So the future is incredibly bright. The challenge with having a bunch of really great tools around, if you can't organize them into a plan to build the house doesn't get built. So what does the house of really great healthcare, wonderful health, and health is more than just the absence of disease. What does that look like? We really have got to have a plan. And my worry is, and you mentioned this before, all these startups that are out there developing all these great tools, they're all wonderful. How does it all come together to create a plan? What are our top priorities as a nation? What are the things that we have to focus on first? The pandemic really put on the skylight things that we knew were there, but we never really talked about. There really is a difference in healthcare access. There really are social determinants of health. There really are things that have nothing to do with what's going on inside your body, but what's going on inside your environment that impact your health and life expectancy. So what's our plan for that? Maybe that's square one. So I think what I'm saying is there's all these great things that are going on together, great things going on in isolation without a plan to unite them with priorities, focus areas, investment strategies, and most importantly, commitment. Really are just great things that are going on in isolation.
Yeah, I think that's important to note that the scope of this is so huge. As much as I kind of have a soft space in my heart for libertarians, right? Self-organized chaos cannot and has not to this point pulled together a piece. So I sat down in an investor's pitch for one of these, I think it was called Doctor's Decisions. It's changed its name several times. And it's like, hey, we're trying to raise X amount of dollars. Are you in? And I was like, gee, this seems like more like a NIH or Bill and Melinda Gates Foundation to do and make this free everywhere with like the Stanford or like the top medical, Cleveland Clinic weighing in and standardizing the best practice for care. But imagine if every piece of this healthcare system, from the admittance, oh, look, we have ways that people pay their copay before they even darken your door. Oh, every little piece gets chopped up into a little startup. You're not going to it's impossible to get the kind of holistic soups to nuts kind of plan that you're going to need to sort this.
And the other thing that's going on, you mentioned the little startups. There's some amazing inventions and innovations and companies out there that are doing incredible work that don't know how to break into the market, that don't know how to come to folks' attention. So it makes it even more challenging to say, okay, let's step back and say, what problem are we solving? What are the priorities that we're solving, or by which we're going to solve that problem? And then who's out there that can help us? And there's so many great innovators out there that just can't break through, come to visibility, don't know how the system operates. That really part of our solution has got to be, how do we empower innovators, bring them to visibility, and make them part of the greater whole? There are just like say, not all great innovations come from companies that are huge, that are very established in the market. There are amazing discoveries and things going on in those companies, to be sure, but there are other smaller companies that really, if we can bring them to light and make that part of a coordinated, cohesive whole, and help those companies succeed and bring their solutions to help others, really that would be amazing.
This is great. So, I think that there's certainly some promise here and certainly some ways and perhaps we can potentially come together and address some of these challenges in a coherent way. What I'd like to shift us to talk about a little bit now is the topic of managing health emergencies at a large scale. Now, you're in a unique position to comment on this. for a variety of reasons. One being that, right after you retired from the Navy, you came to Cleveland State University, and then COVID hit us, and so then you were within striking distance of, hey, you're going to be running our COVID response at the university, and certainly did a lot for other higher education institutions and collaborating there. But then obviously, as the 38th Surgeon General of the Navy, you were involved in a number of large scale types of responses there. So I'm wondering, kind of what you've learned from that, or if you could comment on just that topic of how do you manage these emergencies at a large scale? Maybe we could start with pandemics and kind of your thoughts there.
Yeah, absolutely. And just to go back a little bit of what we talked about earlier, we've had pandemics since antiquity. The bubonic plague has been described since ancient Greece, and so we've had these, and they all behave the same way. They all start out in one area. Usually, it's a zoonotic transmission from an animal to a human. Then there are areas where that occurs more frequently than others. You can predict that. I'm going to come back to predictive analytics, and then they follow the trade routes. The bubonic plague in medieval times did exactly that. They started in the trading posts of Central Asia and migrated to Europe via the trading ports of entry in Italy and a couple other places. And then they spread by roads. The exact same thing happened with COVID. They started, in one part of the world. They followed the airline routes. They came into the United States via ports of entry, New York, Seattle, a couple others. And then they followed to the hubs and then ultimately went from there. Well, if you think about that for a second, the difference is how fast it happened, as we talked about earlier. 5 years to get from Italy to England in the Middle Ages with bubonic plague. Less than 24 hours to get from China to the United States, or anywhere in the world for that. So your reaction time is much, much less. What does that mean? You have to, number one, have a high index of suspicion that there's going to be an outbreak. Things that might not seem important at the time, especially in areas of high risk for zoonotic transmission, like these wild animal markets and things like that. When you start to see people starting to get sick very early on, you have to have a high index of suspicion for that. And then you have to realize these are going to go by trade routes and be able to manage the spread. And then from that, since you know that they're going to go by trade routes, you can do predictive analytics. So you know that if it comes in to a port of entry, likely it's going to spread by the airline routes to hubs. So you know that the next place that's going to be an outbreak is going to be a hub. So that gives you the opportunity to surge medical equipment and personnel to that hub before the infection shows up. What happened, and I think is a lesson learned from COVID, is we were reactionary. We were, short on ventilators and stuff because they were spread all over. But if you use predictive analytics and you understand how pandemics go, you can predict that stuff and then have that stuff pre-positioned and ready to go. You can have a high index of suspicion to be able to know that things are starting, control access, pre-position material and personnel at the hubs, and you can better manage those things. I think that's one thing I've learned, and I've been blessed to be not only involved in the COVID response, but with the Zika response. The Navy did a lot of the testing for the southern United States to support the CDC. With the Ebola response in Western Africa, they all respond the exact same way. The second thing that I learned, and I think this is going to be a big lesson learned for us out of COVID, is the criticality of addressing two things. Number one is transparency of information. And then from that, fear. What drives people's behavior and choices in pandemics is fear. And you've got to be able to address that. And you've got to be able to reassure people. And you do that by being transparent. You do that by not politicizing things. You do that by having a trusted organization that relies on science to be able to advise, inform, and ultimately guide. That not only helps you get over it, but it also creates trust, which helps allay fear. I think we had opportunities to have done that a little bit better. Every pandemic I've been involved in, fear has been a major component. And if you don't address it with information and education and basically say, and these people are going to help guide us through this to create confidence and trust, it really turns out to be much harder. And that's exactly what we saw.
Yeah, were there any moments like during the past year and a half or so that as things were unfolding where you were thinking, oh, we should be doing this instead of this, or things that maybe you learned when you were dealing with Zika or Ebola, that perhaps some of those lessons that weren't used, anything that you saw there?
Yeah, I think the thing that was most striking to me when I look at what happened with Zika, SARS, Ebola, admittedly, those were not as widespread. But what I saw with this was actually, if you read history, somewhat similar, but perhaps not as pervasive in the 1919 flu pandemic, was an infectious disease, a public health issue became politicized. That's exactly what we saw. And unfortunately, and there were reasons for that, but unfortunately, it made it harder to build trust. It undermined trust in institutions that really were put in place and existed to build trust, to help inform, how we respond, to help save lives. That trust was eroded. Messaging, with the instant messaging cycle that we now saw on the internet and with the TV today, we're not in a 24-hour news cycle. We're in an instantaneous news cycle now, with different messaging, created a cacophony of confusion that I think really worked against us, and really undermined trust for that, and created, if you will, an environment where people with different agendas, who perhaps were ill-informed, or perhaps were well-informed but chose not to act on it, really started creating an environment of confusion. And I think that worked against us. I never saw that in previous pandemics.
Yeah, one thing that was interesting is that, early on, I think it was maybe like last May or so, in, May 2020, perhaps. I'll have to go back and check the date. But, we actually, on this podcast, talked about the psychology of crisis communication, and the importance of, being upfront with what you don't know, putting experts out in front. And it was just interesting because, from our estimation, it seemed like there were probably some things that could have been done differently. And when I look forward to the future, big thing that I wonder too is, okay, we've been through this pandemic. Are we going to do it better in the future? Because it's not a question of if another pandemic happens. It's really a question of when. And do you think that we're learning lessons along the way?
I hope so. There's there's a lot of lessons learned from this, about there really are differences in outcomes and survival because of social disparities and different demographic groups. We got to deal with that because there were certain groups that went into this pandemic in poorer health. And so no surprise, they had poorer outcomes. So we ought to be able to deal with that. The importance of transparency and information flow in a rapid news cycle, we have to be able to deal with that. The criticality of building trust, we've got to be able to deal with that. And if you think about it, building trust involves answering just some core questions for people. I think we missed that opportunity. If you're in a pandemic, and we all were, what are the questions you've got? Am I going to get it? You got to be able to answer that. And here's how you prevent you don't get it. Am I going to die? And answer that. And here's what we're doing about that. And here's what we're bringing to bear. Is my family going to get it? Here's what we can talk about that with different demographic groups. Are they going to die? And when is it going to get over? And so communications has got to be built around what questions do people have for this. And I think we have an opportunity to look at how we do strategic communications, to look at how we might raise the health of everyone so that people don't enter pandemics in poorer health and therefore at risk for poorer outcomes. And at the same time, our response using predictive analytics, big data, to be better prepared and surge equipment and personnel to areas of need before they become areas of need, I think present all opportunities for us. Our challenge is we as a country tend to operate on a 4-year cycle based on the elections. And so my worry is that we will go on to the next crisis. And why do I say that? And I'll use our wounded warriors as an example. During OIF and OEF, there was amazing support in commercials and documentaries about wounded warriors. Because the nation was just incredibly grateful. But now we're starting to see that drift from the national stage. Well, these folks are still around. They are arguably the best of our generation because they are the less than 1% of our nation that will wear the uniform, wear the cloth of our nation, and volunteer and sacrifice and serve. And yet we haven't answered those basic questions of what should the future look like for them? What's our national plan to achieve that future? And what's the role of the government? We haven't answered those questions. But now we're talking about a post-pandemic world. Pretty soon we'll be on to something else. So the news cycle means our attention span is short. So that's working against us. So again, the extent to which we can leverage these lessons learned, put politics aside, have an attention span to be able to deal with these lessons learned, I think will position us well. And your point's well taken, Ben. This is not the last pandemic. I mean, viruses are doing what viruses do. They mutate. There will be other zoonotic transmissions because we've had these throughout our history. This will not be the last.
Another thing that I'm wondering is, you've been kind of in this position of being the senior medical person at the helm during a variety of these types of things, either when you were, on active duty with the Navy, and certainly, helping us at Cleveland State University with our COVID response. What were maybe some things, and I'm sure there are lots of things that happened in any of those circumstances that were unexpected and you had to deal with those types of things. What were some of the factors, though, that you think, enabled success, or at least were helpful, or maybe approaches that you took what were some of the things that you did that worked in terms of managing and leading in those environments?
Well, I think probably the most important thing was it was a team effort. Nobody does this alone. Cleveland State is an amazing institution. As you know, they Urban Research University focuses on educating, folks from urban, many disadvantaged, underserved populations. Those students, many first-generation college, many are holding down jobs to be able to go to college because they're the breadwinners for their families, come from very, very impoverished backgrounds. It's an amazing university. And the faculty and staff there are focused on the mission, which is basically providing our students with a future that is bright and full of promise that perhaps they wouldn't otherwise have. And then you get the pandemic that hit. I was amazed by how well the team came together and put in place what we call the 7 layers of protection to give folks. The faculty, over a period of less than 10 days, took the entire curriculum. This is over 1,200 courses, and converted it all online. And there were about 300 or so students that came from backgrounds that couldn't afford laptops to do remote services, couldn't afford internet access. And so the community came together and got them laptops, and the university invested in hotspots for them. We had about 20 or so students that we couldn't send home because they would have gone to chaotic social environments that would not have been safe. And so the team kept the dorms open for them, and we took care of them throughout the pandemic. So what I saw was what I think makes America great: teamwork. And then on a state level, Ohio was perhaps the only state where all the public universities came together and said, hey, listen, regardless of where one of our students, one of our sons or daughters goes, it ought to be the same, and it ought to be on best practices. And all the public universities and colleges in Ohio coordinated their response. In Cleveland State, we were privileged to lead that effort. But I saw that. I saw people coming together to help others. And I think that was kind of the secret sauce. And then the other thing I saw was people took it seriously. So we were blessed. We had one of the lowest infection rates among urban universities in the United States, and we had no outbreaks. We had none of the things that are so because people took it seriously. So I think that was two big lessons for me. Number one, it was a team effort. Number two, people were caring about others to make sure they were taken care of. And number three, there was a focus on doing right for everybody, not just for themselves.
Yeah. So let me ask you about that, because a lot of this, CDC has whole binders and people are practiced on what to do. This was a case of not about us not knowing what to do. It's getting everybody on the same sheet of music and actually doing the stuff we know to do, right? And then maybe, standing on the shoulders of giants and iterating from there. One of the disturbing things that would come up is there's always be some numbskull doctor somewhere saying stuff like, there's alien DNA in the vaccine. It's so obtuse, you can't wrap your mind around it. And then there's, some more insidious ones where people, I don't know, they just want to be Twitter famous. Should there be some kind of public censure because I know, so I come out of an accounting background. I can't just say, yep, the books look good, right? And give an unqualified opinion if I haven't done the audit, right? Like there's a professional standard of conduct when it comes to communicating about what's going on. Is there something like that for doctors? Should there be? I mean, what do we do with jackwagon doctors?
Yeah, that's a great question. One of the amazing treasures of being an American is freedom of speech. The cost of freedom of speech is everybody gets to speak. And just because you're a doctor doesn't mean you're immune from either mental illness.
Right, but there's got to be something from a professional. You're speaking as a doctor, not a lay person, right?
Yeah.
Surely there has to be some kind of professional censure there.
There's freedom of speech. There's two parties to this. One is the person actually doing the speaking, and again, everybody's got a right to their opinion. And then there's the people that give them a stage by which to share that opinion. And quite frankly, we rely on those people, to make sure that stage, the people on that stage, are credible, are responsible, and really are reflective of. Again, for me, I'm a very big believer in the science, are reflective of the science and the data. When we have folks that give the stage to people who perhaps are touting something that we know is just not true or stuff because they're looking for ratings or things like that, then I think we have to ask ourselves, as a nation, is that ethical? Is that moral? How does that help Americans? And I've got my own personal feelings on that, but I think it's a two-way street of everybody's got a right to speak their mind, but not everybody has a right to be on the stage to speak that mind to a broad audience. So how do we manage that stage?
Yeah. So let me push back on that a little bit, Dr. Admiral. So right, we do it live at the Indigo Podcast.
Yeah.
So we have a term for that, and it's called deplatforming. But if you are a journalist or a media company, how are you going to be able to call strikes and fouls on a medical professional? That's why I'm thinking I'm still leaning towards not that somebody can say, hey, I'm concerned about this. Or maybe early some docs were like, well, we got nothing, so we'll go with hydrochloroquine. But what we got nothing. We're trying here, right? When they're in those emergent places, but when somebody comes out and says something that is just summarily false by any kind of standard of care, you don't support any kind of professional censure from, like, I don't know, how you guys get credentialed or something?
Yeah, it's difficult to censure someone in a country that values and treasures and have people that have died for freedom of speech. What I would say is, most of the major organizations that maintain these stages, if you will, have got medical expertise and medical advisors. I would hope that they are using them. So when you get somebody that says, "Hey, I want to get on TV," as an example, and talk about how the vaccine has got alien DNA in it, I would hope that TV producer is calling their medical advisor and saying, hey, doc, what do you think about this? And there is a conversation.
Well, I mean, the problem is they can go to Twitter, right? They could just go straight to the people.
Yeah.
And so I don't know how Okay.
But we have had that. We have had that since antiquity. Perfectly. Again, I'm a student of history. If you look at the bubonic plague in medieval Europe, they burned people at the stake because they thought they were poisoning wells. They thought that the well poisoning was a cause of the bubonic plague. In one of the towns in one of the countries in Germany, all the people of the Jewish faith were murdered because they thought they were causing the plague. There were people that were doing all sorts of things. You're always going to have those people. So you can choose to say, okay, we're going to censure them, but probably might not be effective. Or you can say, but let's make sure if they do get the stage, it's balanced. Let's make sure that we're providing opportunity for those that are credible to provide the same message, or to provide a message that perhaps is more reasonable, more reflective of the science and of the data. I think we have opportunities there.
Yeah. So, and just to clarify for our listeners, I'm saying censure, not censor. So maybe there's a public statement. Yes, he's a licensed medical doctor, but the American Society of Physicians thinks he's a jackwagon medical doctor.
Yeah. Well, there's the medical profession. I'm sure some of those people that have spoken like that are gonna find it very hard to get referrals from their colleagues and stuff. So I think there are things that the medical profession it does. I don't know this to be true, but I would say, I'm reluctant to say let's censure or impede freedom of speech. I think a more successful route would be, let's make sure people are informed with the facts. And that gets more to transparency. Because if people are armed with the facts, then when somebody shows up saying, hey, there's alien DNA in the vaccine, it's a lot harder to make that case.
Yeah. Yeah, I think would be a recommendation really for everyone is that basically everyone should be listening to the Indigo Podcast, because we are very careful in who we allow on here, and we make sure that we have evidence-based professionals who aren't going to say crazy things. So
only the people Bill Gates tells me to put on the show get on the show.
There you go. So this has been a fascinating conversation as we start to kind of come into the home stretch here a little bit. We've mentioned a couple times that you were the 38th Surgeon General of the U.S. Navy, and I think it would be nice for our listeners for you just to explain a little bit about what is that job anyway, and what were some of the things you took away from that, lessons learned or things that might be helpful for other people out there.
Yeah, thanks very much for that question, Ben. So the Surgeon General of the Navy, and each of the services has one, is the CEO, the Chief Executive Officer for Navy and Marine Corps medicine. So for the Navy and Marine Corps, that's 67,000 men and women, pretty much in every time zone, in about 128 medical centers, hospitals, and clinics, medical departments in every unit and on every ship, research labs around the world, graduate education programs, caring for about 2.6 to 2.8 million people, with a budget of about $9 to $12 billion. And our job is to safeguard and preserve the health of the fighting force and take care of their families, retirees, and others. Train folks who will go forward in harm's way to save lives, and be prepared to respond. Our nation expects our military to fight tonight to defend our freedom. If you're going to fight tonight, you have to be prepared to save lives tonight. And so the Surgeon General, as the CEO of that global multi-billion-dollar large healthcare enterprise, is responsible for keeping people healthy, being prepared to save lives tonight, managing healthcare so that is best practice and things like that. Everybody that joins our military, and as I shared with you earlier, today less than 1% of our nation will volunteer and sacrifice and serve in uniform to protect and defend us. Less than 1%. And to every one of them, we make a commitment to them and to their families that we will provide them the best care our nation can offer, and one day return them home safely with the grateful thanks of our nation. The Surgeon General is responsible for ensuring that that health system is run to be able to do that. And so that's kind of what they do. So, you manage all the things that a CEO would manage of a major healthcare system, a global healthcare system. And I was privileged and honored to do that. I will tell you, I have never been so proud to be an American than when I would go out and I was privileged to command in a combat theater for a year. I ran a combat hospital and things like that. When I see these young men and women who are not in it for themselves, they're not in it for fame or glory, and they're certainly not in it for the money, but they're in it because they want to help and they want to make a difference. I have no worries about the future of our country when I look at the men and women who are serving in our military today. So that's kind of, I think, the big thing that I learned from that. The other thing I learned is the importance of strategy, and we talked a little bit about this earlier. In Iraq and Afghanistan, as I shared earlier, we had the highest combat survival in history. If you had a survivable injury, and there are some injuries that are just not survivable, but if you had a survivable injury on the battlefield in Iraq and Afghanistan, you had a 97% chance of survival. That's the highest on record in history. And again, routinely, men and women who would have died in any previous conflict were being saved and were coming home with their entire lives ahead of them. We are only one of just a few countries that maintain a standing medical force to be able to get out the door quickly and save lives tonight, to be able to do that. And our country benefited from that because of all these wounded warriors that survived and will now go on to contribute to our nation through the rest of their lives. But it's not cheap. We came home to a country that didn't understand the cost of military health care. And so there was while I was the Surgeon General, undertaken the most expansive reform of military health care that we've seen in over 50 years, with the intent of trying to save some money as the military looks ahead to a global stage that is far from secure, with the rise of resurgent Russia, China, some of these other potential adversaries. Then we need to be able to look at investing in weapon systems, recapitalizing ships, and things like that. So there was a great deal of focus on the cost of healthcare and trying to find efficiencies and be able to do things to find savings to plow back into weapon systems and things like that. So that's all fine, except it's important to have a strategy for that. And so I spent a great deal of my time up on Capitol Hill and talking to our elected officials and leaders inside the Pentagon. What problem are we solving? What does success look like? And what are those things that are critical for combat survival in the future that we must make sure that we preserve? And it's hard to answer those questions. I'll just say the answers I got when I did get answers caused me to realize the importance of having a strategy, because every mom and dad in America whose son or daughter is serving in our military today expects that high combat survival, and we want to deliver that. So as we shift focus from Iraq and Afghanistan, where we weren't fighting peer adversaries, to potential peer adversaries in very different theaters where we may not have some of the advantage that we had before, what do we need to preserve? What does this health system need to look like? And what needs to be preserved to ensure that high combat survival, that we can continue to make good on that trust that's placed in our hands to provide the best care our nation can offer and every opportunity for combat survival? I learned the importance of asking those tough questions because as a leader, who's going to ask those questions if you're not willing to do that? You got to have the courage of your convictions, be willing to tell truth to power, and be able to ask those tough questions, because every service member, every mom and dad is depending on you to do that. And those are important questions that we don't want to be answering when we're going out the door to fight a war. We have a window of opportunity now. Again, we've had wars since antiquity. We have a window of opportunity to get that right and make sure that health system is well positioned for combat survival in the future. And so I learned the importance of strategy with that. So my takeaway, I have never been so proud to be an American. When I see the men and women that are serving in our military today, do we have challenges ahead on a global world stage? Absolutely, we do. Are we going to be expected to get out the door tonight to defend our freedom and save lives? Absolutely, we are. Do we need to make sure that we are well prepared to continue to honor that trust that we have honored every day since the founding of our nation, to do all in our power to safeguard the health and preserve the lives of those that will wear the cloth of our nation? Absolutely. That trust will not change. We have to make sure that we're prepared to answer it.
I'm so glad you talk about these things, because I always get this sentiment from civilians that we're a bunch of automatons that don't think, that don't have, even at the senior level. I mean, I've seen general staff yell at each other on disagreements, right? Like, we have different backgrounds. We are a crosscut of our nation's everything, ideas, political affiliations, stinking thinking, the whole bit. And I gotta say, you should join the military. And Forrest, I want you to if you were to tell somebody who's thinking about maybe joining the military, because guys, you can be creative and have leadership potential to do, like he was global leader in healthcare. Have a fun time, hard time fighting your way up to that on the civilian side. You'll at least get an at-bat in the military. But why would you tell somebody it's a good idea or not to join the military at this point?
So I do a fair amount of mentoring for students at CSU and elsewhere. And I ask them two questions. Number one, well, I tell them two things. Number one, what's the purpose of your life? Answer that question first. And then the second is, I tell them where you think you're going to end up is not where you're going to end up. But always be looking for how can you best answer the question, what's the purpose of your life? So I grew up in Rocky River outside Cleveland, and I went away to college at Wake Forest, and I went there with the intention of becoming a minister, because for me, the purpose of life is helping people. And I thought that'd be a pretty cool way to do that. You get to wear some cool clothes once a week, a lot of free food. It's not too strenuous. And I thought you only needed to know one book, so I'm in. And when I was there, is when the steel industry had its challenges, and my dad lost his job and got transferred to another job down in Washington, D.C. And I couldn't afford to go to college at Wake Forest. So I got a summer job in this brand new medical school the military was building called the Uniformed Services University as a lab assistant, cleaning test tubes and taking care of lab rats, stuff like that. But that's how I paid for college. But I also learned about medicine. And I learned that, hey, medicine's a pretty cool way to help people. And maybe I'll be a doctor. And I couldn't afford to go to medical school, so I applied to the military medical school, and I got in. And I realized that here's a career where you're part of something greater than yourself. You're not in it for the money. You're working with people who are not in it for the money. You're working for people that are defending our freedom, and really allowing us to ensure that the world that we leave our children is better than the world that was left to us. And I was pretty excited about that, and I got to see some amazing things. I got to help people in ways that I could never have helped them before, from helping out with the response to the Haiti earthquake, to the Fukushima disaster, to the Zika response, Ebola, on ways that I could never have imagined when I was growing up as a high school student in Rocky River. But again, I go back to take the time to answer for yourself, what's the purpose of your life? And then as you go through life, where you end up is not going to be where you thought you were going to end up. When I was a high school student in Rocky River, I had no idea I was going to be in the Navy. The Surgeon General was some guy on a cigarette carton. And I had no idea I was going to do that, much less that I was going to come back to Cleveland State to help these amazing young students, with their futures. But what I did learn was at each point along the way, does what I'm about to do help me with the purpose of my life? And that's what I tell people. And for me, the military was an amazing way to be part of something greater than yourself, serve your country, and ensure that the world that we pass on to our children will be better than the world that was passed to us.
Well, Admiral, it has been an absolute pleasure having you here on the Indigo Podcast.
Well, Ben, thank you so much for the honor and privilege. I'll tell you, the honor is all mine, and I've so enjoyed talking to both you and Chris. This has been great. Thank you.
Thanks for listening to the Indigo Podcast. If you like this podcast, please consider helping us by rating us on Apple Podcasts or wherever you listen, telling your friends about us, having us on your podcast, or mentioning us on social media. Our website is www.indigopodcast.com, where you can access more information about us and this episode. Thanks again, and we look forward to talking with you again soon.